Hi, good evening, everyone, and welcome. I'm Dr. Marlene Rabinovich, and I am the director of the new Basic Science and Engineering Research Initiative of the Betty Irene Moore Children's Heart Center at Stanford. So I'm absolutely delighted on the behalf of all my colleagues to be here this evening to discuss really innovative and bold approaches to discovering new treatments and ultimately cures for children with heart disease. So thanks so much for being part of this initiative with us tonight. So to set the stage for this conversation, I'd like to share some background about children's heart disease. First of all, it's the most common birth defect. 1 in 100 children are born with a structural heart defect that needs corrective surgery. Um, and many of the children with these defects are referred to our hospital because of the complexity involved, not just one operation, but often multiple operations till they reached adulthood. So when I started my career, many of the types of conditions that we see weren't really curable and weren't even treatable, never mind curable, because there were just no operations available. But over time, and I would say within a period of 1 decade, new and innovative approaches allowed us to save the lives of many children with congenital heart defects. And we've made strides over the subsequent 2 or 3 decades. But at this point, we're reaching a plateau. And the reason we're reaching a plateau is that the children often require still multiple operations, each one taking a toll on their heart. And we see many children that, while they may have relatively normal lives during early childhood, succumb to later heart failure, heart rhythm abnormalities, and require further treatments and even a heart transplant. So about 5 years ago, Dr. Hanley came to me and said, we really need to transform the field so that we're not just treating children with heart disease and we're not just saving their lives, but we're actually transforming their lives by curing the problem. And recognizing that this would only come through innovative initiatives in basic science and engineering, we developed this program. And so tonight, what we'd like to focus on is the engineering piece of what we do at the Basic Science and Engineering Initiative. So each of our scientists that I'm going to introduce in a moment, but each of our scientists in the BASE program, and we have 4 now, work within the basic science and engineering departments to recruit graduate students, postdoctoral fellows, and their colleagues to work on children's heart disease. So the leverage they have is absolutely tremendous. Many top scientists on campus, and you'll hear a little bit about that later, who had no idea about children's heart disease are now working towards the cure with our lead scientists. And we have investigators like Dr. Enritz, who are at the cutting edge of gene editing and genome sequencing, Casey Gifford, who fits the developmental piece to the genetics, Xiaoji Qi, who is actually a phenomenal computational biologist who's building 3-dimensional models of the heart so that we can pinpoint which cells at which time in development go wrong. Those are the ones we need to correct. So I'd like to introduce you to our panelists and share how their unique engineering backgrounds are going to change the game for heart disease research. Dr. Michael Ma is the chief of the Division of Pediatric Heart Surgery here at Packard Children's Hospital. He has a degree in chemical engineering and leads the cardiovascular engineering research lab at Stanford and is using his engineering mindset together with his surgical skills to develop new therapies for children. He works very, very closely with Drs. Marsden and Mark Schuyler Scott. So Dr. Allison Marsden is professor of pediatrics in cardiology, but also in bioengineering and in mechanical engineering, and even has a background in aerospace engineering. So she's using her expertise in fluid dynamics and in computational biology to optimize surgeries, to improve patients' overall outcomes and quality of life, but also to design the approach that Dr. Mark Schuyler Scott is going to implement in building a heart from stem cells. Dr. Mark Schuyler Scott is an assistant professor in bioengineering at Stanford with a background in mechanical engineering and materials science. And he has taken on, through the auspices of the ARPA-H, the audacious goal of building a whole heart and heart valves from a patient's own stem cells. So I hope you enjoy hearing from each of them. I'll throw out the first question for each of you to answer. Mike, let's start for you. How will engineering play a role in the future of children with heart disease?
Hi, everybody. Thanks for having us tonight. Thank you for the very kind introduction, Marlene. It's been a pleasure to work with all of you for all these years, and it's a pleasure to speak in front of you today. So for your question, I think, how does engineering play a role in cardiac care? I would say historically, cardiac surgeons have always tried to be engineers in their own sort of unsophisticated way. If you think back to the history of modern open heart surgery, we've been doing that since the 1950s, and we've been largely experimenting on young children and adults who've been desperate because we don't have a more sophisticated way of doing things historically. We have resorted to trying all of our novel therapies on patients who are very desperate for better therapies to help improve their lives. I think in the modern era now, we are at a time where true, very sophisticated engineering efforts can be utilized to help improve the way we do modern cardiac surgery, both for young children and for adults. And the analogy I always provide for people is that I think it's pretty ridiculous that we can design an airplane now on a computer, and we could fly that airplane in a virtual simulator, and we can decide right then and there if that airplane design is a good design that would then undergo the appropriate manufacturing and research and development to become an actual airplane that flies people from point A to point B. Modern cardiac surgery doesn't really work that way. It's still about designing the airplane in real time, in a real patient, on the fly, while that patient's heart is stopped on the operating room table. And so I think the power of engineering is to be able to bring a lot of those concepts that we can design the right surgeries and the right therapies for patients before they show up on the operating room table, so that we can fix them and know that it's going to be fixed appropriately before we try to experiment on all the little children and adults that we're trying to take care of. So I think at a very high level, that is how engineering now can intersect very appropriately with cardiac surgery and other types of surgical and medical innovation. I think, that's a good segue to let Allison chime in a little bit about how her engineering efforts have really helped people like me do the job I do better. And Mark will probably have very similar things to talk about, but in his own vein. So thanks.
Yeah, thanks, Mike. I can build on some of what Mike was saying. So Mike and I have had a great collaboration in working on incorporating some of our computer modeling methods into his clinical practice. And in fact, in one recent example, he's actually changed the way that he's doing valve reconstruction surgeries as a result of some of our modeling efforts. And so as Mike was saying, we're all familiar with kind of traditional engineering approaches where one uses predictive computational tools to design things like airplanes, cars, SpaceX rockets, and things in that vein. And so what we're really trying to do in my lab is take a lot of those tools that have been developed over many decades for those types of traditional applications and really leverage them and apply them and modify them appropriately to apply to the cardiovascular setting. And so that's where my background and training in aerospace engineering and fluid dynamics and computational science comes into play. And of course, it's not so simple as just take this tool and apply it over there. We have to really think carefully about how to incorporate things like biology and physiology and clinical needs. And of course, we have a lot of interactions with clinicians like Mike in bringing those tools to bear. And of course, in another very exciting direction, we're working with Mark Schuyler Scott on some new applications. And so I'll turn now to Mark to tell us about how you think engineering plays a role in cardiovascular disease.
Thanks, Allison. Yeah, I guess the heart is an amazing organ, looking at it as an engineer. It's a pump that lasts for a median of 70 years. we engineers have not figured out how to make a pump work without failing for more than a couple of years. So really, the heart is the very best pump that exists on planet Earth. And it's incredibly inspiring to work with living material and to figure out how to craft it as an engineer to do, some amazing things. And one of those amazing things, of course, is to be able to potentially replace a heart that is 3D bioprinted with a 3D bioprinted heart made up of your own cells. It's an incredibly difficult task. I would call it not low-hanging fruit, but high-hanging fruit. But I think it's our role in academic medicine to think about those really hard problems. Industry will always throw its money and challenge, and workforce at low-hanging fruit and maybe the easier problems. But we have a role to really think, what should medicine look like in 20 and 30 years' time? And to me, that's just fairly straightforward. It is, you've got a broken heart. Well, here's a new heart made of your own cells that can really extend your healthy lifespan. And I just find this such an exciting path and journey to take. So, of course, there's an incredibly difficult challenge to make a heart. We need billions of cells. This isn't a few cells in a petri dish. This is a kilogram of beating functional human organ, and all of these cells need all of the energy supplies and blood vessels, right? Alison has told you about how she is able to predict how blood flows through different shaped vascular networks. Well, what if we could make those vascular networks based on Alison's ability to predict what would be the best network to feed our bioprinted tissues? And we're working on all sorts of new technologies, not only on making the billions of cells, but also how we will print them into the shape of a heart and with the blood vessels and valves that are ready to go into a patient, and we need to do so quickly. So we're working on new methods that can rapidly bioprint stem cell derived tissues so that the cells can survive the process. Many of you that have touched a 3D printer may know to make something at the scale of a heart could take days of 3D printing. We just don't have that time when we're working with living material. So we're really excited to kind of push the envelope on the hardware, on the materials, on the stem cell biology. But really, this should be the future of medicine, right? If your heart is broken, that you receive your own heart made up of your own cells. It's a long journey, but we're figuring out the key steps along the way.
Yeah, I mean, Mark, that's super exciting. Alison, also super exciting. I'm glad to have been able to work with you guys for all these years, and I'm looking forward to many, many years more to get to the high-hanging fruit that we all hope to achieve together. I get asked this question a lot, and it's not specifically for this audience, but just listening to you guys talk about the work that you're doing and the work that we're collaborating on really has helped me appreciate being here at Stanford. I'll just give a quick anecdote. I did sort of brag to some of my colleagues, all pediatric heart surgeons in the country, we all know each other because there's only about 200 of us in the country. So we get together every year and we try to talk about how great we're doing and how awesome our work is. And it just so happened at one of these recent meetings, I was meeting with a few of my colleagues at one of the other really top institutions in the country, and they mentioned that they were doing quite a bit of valve design work. They were talking about how they wanted to improve transplantation of organs. And I just mentioned in passing that I'd been doing a lot of this work that we've been talking about tonight, and they were really, really envious of what we have. Some of these other large institutions, they are large research institutions, but I think the difference between what we're able to foster here and what's able to be done anywhere else in the world is the fact that the schools of medicine, engineering, and basic sciences all really talk to each other quite well. We live on the same campus. Our offices are within a city block of each other. We have regular meetings where we're able to chat and collaborate and talk through different problems. And I think that's a luxury that I can't think of another institution that is doing pioneering work that is able to do this type of collaborative work. And as just one example from my own clinical practice, we often get these challenging cases where we're not exactly sure how we want to do the operation. And we are trying to leverage the abilities that we talked about before. We are trying to bring in engineers to decide how to best design the operation before we start it. And I probably do that once or twice every 3 to 6 months with the team that's in front of us here tonight. And it's really made a difference for all of our patients.
Great. Well, I'll just expand on a little bit of those ideas with regard to why Stanford is the place to be for doing this type of work. You know, as I travel around the country giving seminars at various other institutions, it always strikes me how rare it is that we have, and you've probably heard this before, but it's really, really important. We have co-located really top schools of engineering, medicine, and basic science, humanities, and other schools on the same campus. My lab is in the Clark Center. I can literally see the hospital out the window of my lab. We can walk over there in 5 minutes. I can send my students over there to interact with people like Mike and go to his lab meeting. And that's something that they're doing, you know, on a weekly basis. And you know, so not only do we have these things co-located, but we have really top programs in computational science and engineering. Of course, people doing things like machine learning, and we've really pioneered a lot of these tools for patient-specific modeling. Of course, we had Charlie Taylor on the faculty previously, who founded the company HeartFlow, which received the first FDA approval for simulation-based technology in cardiovascular disease. We also have a much less siloed culture. So I think being on the West Coast in California, I don't know what it is, but something in the water, but we have a lot fewer barriers to crossing disciplines just culturally on campus than many other places. In my lab alone, I have PhD students from about 4 or 5 different programs on campus, and they all sit together and work together, and that really fosters communication and innovation. And of course, as Mark will tell you, we have the best bioprinter anywhere in the country. So Mark, maybe you want to take over from here.
Thanks, Alison. It's a pretty great printer we have, and pretty unique technologies that we're developing. But just to, you know, really build on Mike and Alison's points here, tell me any other institute in the US with a top engineering and top medical school co-located, right? Top engineering, you think in MIT, has no medical school. Top medical school, you're thinking Harvard. You know, engineering is a long distance away, and very hard to collaborate so seamlessly with basic scientists and, you know, engineers and doctors. And that's what it takes to make a heart, right? We need a lot of the best stem cells that exist, the best protocols. We need the best basic scientists to make our raw materials. We need the engineers to figure out how to craft it with a 3D bioprinter and come up with the algorithms of how we deposit all of these cells. And we need the best surgeons to figure out what the heck they're going to do with all the tissues we're giving them. And it's just great to be working, you know, not only in the same place, but, you know, on grants we've all written together and are funded together. So we're really, you know, very deeply integrated. And as Alison said, I'm pretty sure it's something in the water, because I drink straight from the tap and not from filters. So I'm getting a strong dose of that. Yeah, it's a phenomenal place to work, and I'm just really excited to see what all of this collaboration is able to bring over the next 2 to 3 decades of work.
Yeah, I couldn't agree with you more, Mark. I think, you know, I'm really hopeful for the future because of the power of these engineering tools to impact clinical care. And in particular, you know, we really want to personalize the treatment plans for different patients. For example, starting with their image data, their personal anatomy, especially in congenital heart disease, every patient that Mike operates on is different and requires a customized, individualized plan. And so we really want to now leverage, I think we're on the cusp of really deploying at scale these kind of computational predictive tools for individualized treatment planning. And this is going to provide a more predictive way to try multiple scenarios on a given patient, you know, try 5 different methods or 5 different scenarios before Mike takes a patient to the OR and actually performs a procedure.
And this is a tremendously exciting strategy, Alison, to really get the most out of the tissues that are available. But as you and Mike know, the sad reality is that, even with the best modeling, there's just not enough tissue. Every child that needs a heart transplant, may not end up getting one. And we really, want to try and overcome that using our 3D bioprinting and creating the patient's own heart made with their own cells. And for example, using your models that can really identify the right geometries for this specific patient. Every patient with congenital heart disease has different structural malformations. The ability to bioprint specific cures for specific patients is particularly exciting in this space. Mike, what's your hope for the future?
Yeah, thanks, Mark. That's a pretty deep question. A lot of things give me hope for the future. I think, just listening to both of you talk today has given me a lot of inspiration for the work that I continue to do in the hospital and also with both of you in our different research labs. On a personal level, I think my kids are really quite motivating. I know Allison's had kids, and Mark, you're a young father. So for me, seeing my kids healthy, laughing, that gives me a lot of joy. When I'm in the hospital, I see a lot of families struggling with the same things. They have young children that are really suffering, and some of these parents are staying in the hospital for months to years on end, watching and hoping that their child gets better. So I think in the face of that much need and that much desperation and love for one's own children, that's what gives me hope that we will continue to make the strides we need to make. These are the things that motivate each of us to do the work that we do, to make, as cliche as it sounds, to make this world a better place for our kids. And I think the three of us are very intimately involved in that endeavor, in different capacities. But at the end of the day, that's what motivates each of us to do what we do. And I think that gives me a lot of hope that the next generation is going to be better off than the current generation. I mean, just historically, it's the same types of people that helped make kids today. I see 30-year-olds today that would have never survived the operations that were invented for them 25, 30 years ago. But those kids are now adults. And I think there are 30-year-olds now that are dying soon that are going to benefit from the technology that we're able to create together now, so that the kids that are 30 years old now that are going to die next year, they're going to make it to 80. And so I think that's really crucial to me for why each of us does what we do. And it's very gratifying to watch that process and be a part of that process, wherever that road takes us.